To breathe or not to breathe? Everything has to. How is the question? All right, so we'll go. Anatomy, physiology review. Understand the difference between oxygenated ventilation versus respiration. I'm going to throw some pulse and stuff in there, even with the respiration side of it. Because the lungs and all that stuff, the pulmonary system has direct interactions with the cardiovascular hand in hand. So you have to talk with about one to be able to talk about the other from that standpoint. And then, of course, we'll go through the cases. All right. Breathing, okay, ventilation. It's the process of bringing in oxygen into the body and getting rid of CO2, right? Case class, case done, class dismissed. Have a good day. Take your 3 hours and leave the door. All right. That's really the mainstay point or the main focus of what we're going to be talking about. Okay, how do we get oxygen in? How do we get CO2? And what's the importance of both of those? So what's in there? Okay, what do we breathe in? Okay, the majority of it is nitrogen, 78% of it, 20% oxygen, a little bit of argon, and the rest of it is some other different gases and all that stuff. Reasons that we use nitrogen. Why do we use nitrogen? What's the purpose of having nitrogen in the air? What does that do for us? Why do scuba divers breathe nitrogen? What? Yeah, it's actually, it helps with turbulence. So with nitrogen being one of the noble gases, it actually helps or it stabilizes turbulence, so you don't get a lot of turbulent flow going through. Okay, so that's one of the major reasons, and it's just there. And then of course we need the oxygen, and from that standpoint. Kind of sort of how we're split, upper airway versus lower airway. Your epiglottis is the glottic opening, is the cutoff, or that's the differences between the upper airway and the lower airway. Okay, upper airway, it's our mouth, our nose, and all that stuff. Oropharynx, the nose comes together into the back of the mouth, so to the mouth, the tongue in the back, and then it goes down into the larynx portion of there. Glottis sits over top of. The epiglottis sits over top of the glottic structure and all that stuff. All right, we good there? Yep. All right. Lower airway, okay. We have from there, from the glottic opening, okay, epiglottis sits on top of that. You got the trachea that comes down, thick rings and all that stuff for the trachea, and then it bifurcates into your main stem, your left and right bronchus, and then it goes into the little bronchioles, and then ultimately into the alveoli, okay. How many lungs on the left side? 2 lobes on the left. How many on the right? 3. Okay. Why do we have 2 on the left?
We're getting room for the heart.
Okay, the heart's all that stuff. Okay. How many ribs down is our lungs? How far down does it go into the back? Because the front it's actually about the 7th, 8th rib. Okay, and how far into the back? 10th, okay, so the back of the lungs are actually longer than the front of the lungs, okay? So if you get stabbed or shot in the back, okay, you can potentially hit a lung versus getting stabbed and shot in the front. So just take that into considerations and all that stuff, okay? Adult versus kids, okay, what kids, okay? How are their airway? What's their airway like? Small airway, what?
Tongue is a larger percentage.
Yeah, big tongue, okay? What about their head? Big head, so what happens? Yep, big occiput. So what happens with their airway if they're laying flat?
Crimped off.
Okay, it gets clipped off. Okay, so what do you may need to do if you're going to intubate them?
Pat under the shoulders.
Patting on their shoulders. Okay, you want to get into those. Yep, tilt the head back. The sniffing position. Okay, it's just a little bit. It's not way kinked back. It's just all you do is like you're trying to sniff a rose. So you lean your head forward and you take in that breath. That's what the sniffing position is, and that's what you're trying to maximize. It's the 3 axes or the 3 alignments. Okay, so big tongue, big head, small mouth, small airway. What's the narrowest part of their airway? Is it the glottic opening or is it below the glottic opening? The trachea, okay? So it's actually below the glottic opening, okay? So it's right at where the cricothyroid or the thyroid membrane or the thyroid organ, the cricocartilage and all that stuff, that's actually the narrowest part of their airway, okay? So that's why if you drop a coin into the glottic opening on a kid, that's why it can get in there and then it gets stuck, Okay, versus adults, what's the narrowest part of their airway? It's actually the glottic opening. Okay, that's why a coin usually won't go down inside an adult. Okay, so you don't have to worry about fishing stuff out of the trachea. You're just covering the hole from that perspective. All right. So again, for kids, if we go into criking kids, what's the age-wise for them? 8, okay? And it's usually because of the cricothyroid membranes. That's the smallest to be able to get a 6-0 ET tube through. So actually smaller kids, age 2s, we actually do, we don't do crics on them, we do trachs. So we actually will cut the tracheal ring and then put a ET tube in and all that stuff. So different plays, different schools. All right. The lungs and all that stuff, again, 2 on the left, 3 on the right, okay? The posterior is bigger than the anterior. You have 2 different coverings, the pleura, okay, that's what covers the lung itself. The parietal versus the visceral. Visceral means organ, so it's attached to the lung itself. The parietal, if you think of it, it's the parent, okay, so it's going to cover everything, okay? If I separate the pleura, if I separate the visceral from the parietal, what do I have? If I shoot you in the chest, you got a pneumothorax, okay? And if I put fluid in there, you got a hemo potentially or just pleural effusion with the fluid thorax and all that stuff, okay? So the actual space between they touch each other, it's when you actually spread it apart, it's a theoretical space, and that's how we get our hemothorax and all that stuff.
How do you get pleurisy?
Well, pleurisy is irritation of the pleura, okay? So anything that causes that irritation, viral illness is the most common from that standpoint, okay? Some drugs can, irritants and all that stuff, they'll do some of the disease, scleroderma, lupus and all that stuff, you can get pleurisy. HIV can get pleurisy. All right, really geeking here, okay? Histology. So what is our lung actually made of? Okay, so if we look at the different cells, okay, from that standpoint, we have these basal cells, Clara cells, variant Clara cells, ciliated cells, basics, neuroendocrine cells, and it's the AT1s and the AT2s that we want to talk about the most, okay, because that's the majority of what R is. And then endothelial cells, the goblet cells, all these weird cells, okay? The AT1 and AT2s, those are our lung cells for the most part, okay? The AT1 is the ones that actually allow for diffusion, okay? And then the AT2s are the ones that make surfactant. Question?
Not really.
Okay. You're like going, oh my God, Lord, this is, again.
No, he asked if I wanted to slide.
Yeah, so really geeking here, okay? The goblet cells are the ones that make mucus, okay? That's what we spit up. You have the ciliated cells, those are the ones that have a little cilia on it that causes us to be able to move stuff out of the lungs, okay? The AT1s, again, those are the ones that they're down in the alveoli and allow for the diffusion of oxygen across or the CO2 back across. And do you have to know all this? No, okay? But I want you to understand there's a lot of different types of cells in our lungs. Right? It's just not just the endothelial cells and all that stuff.
And the type of cancer you have is like basal cell carcinoma.
Correct, yep. Yeah, you can have basal cell carcinoma, and then you can have squamous cell carcinoma in the lungs and all that stuff. Adenocarcinoma, neuroendocrine tumors in the lungs. So you have a whole bunch of different types.
This will be
like with cystic fibrosis. Okay, cystic fibrosis, what's their major problem? They lose some elasticity, but they can't actually get rid of it. It's a chlorine problem, okay? And it's the ciliated cells that actually are the ones that are the problem. So they can't move things they can't get rid of. They have a lot of gunk in there. So again, understanding the anatomy and the physiology, now you understand the pathology or the processes behind it.
How does sweat determine if you have CHF or cystic fibrosis?
It's looking at the chlorine. When we do a chlorine sweat test. All right. Inside the alveoli. Okay. Woo. Through all that stuff. Alveoli. The terminal pros, again, if you think of the alveoli as like a grape or a sack of grapes, okay, you have the little stem, you have all the little stems that come off, and you have all the little grapes around it. Those grapes are the alveoli, okay? They are small enough with the aspect of the capillary beds that go around it. There's only one blood vessel or one blood cell that goes through the capillary around. That's how teeny tiny they are, okay? And that allows, again, from the aspect of diffusion, CO2 out of the bloodstream, oxygen from the alveoli into the bloodstream. That's their whole purpose. If I throw a little bit of fluid in there, what happens? CHF, pulmonary edema, anything from that standpoint, pneumonia. How well do we oxygenate or ventilate, or how well do we oxygenate or diffuse stuff across? We don't. It sucks, okay? So that's why we have to be able to clear things. Conversely, though, okay, so if we look at how the oxygen level occurs. So our oxygen level at the top, when we breathe in and out, we're at about 104, it's the partial pressure of oxygen. So the number of molecules, kind of sort of, if you think about it. We're at 104 at the mouth. And then as we go down from the mouth to the trachea, all the way down to the very bottom, our partial pressure drops down to 20 of oxygen. Conversely, at the bottom, our CO2 level is high, 46, and then it goes up to 35 to 45. So when we do our end-tidal CO2s, what are we measuring? What's a normal end-tidal CO2? 35 to 45. And this is the reason why it's 35 to 45. Okay. On the right-hand side is the zones of perfusion. I said that the cardiovascular system and the pulmonary system work hand in hand. What's happening at the top part of the lungs? What do you see or don't see? You don't. It's not, blood's not getting there, okay? So we actually don't get blood to the top part of our lungs, which means that what about diffusion of oxygen across? Do we diffuse there? No, we can't, okay? The middle portion, okay, is where the majority, if we're looking at our lungs here, where's our partial pressure? We have the majority of our oxygen is actually occurring, it's high at the top, but it's lower at the bottom, but we have the majority of our blood is where? In the bottom of our lungs. Okay? That's why we have problems if we get CHF, because where's the fluid for them? In the bases. So we can't oxygenate where the majority of the blood is, and that's the issue. Versus the middle portion that it fluctuates and all that stuff. Okay? That's the pieces of the puzzles. Right. How do we control? Okay? Brain stem and all that stuff. The brain stem's the majority of our neural control. Okay? That's all the electrical side of it. But it's all regulated through chemoreceptors. Okay? It's all acid base. That's how they get everything. We have chemoreceptors in the brain stem. There's 3 inside the brain stem. And then we have at our carotid bodies, and then also at the aortic arch, and then inside all the muscles. Okay? All of our muscles have chemoreceptors from that standpoint. What do they look at? Okay? The ventral respiratory group, the dorsal respiratory group, and then the pneumatic tactic center. That's the major one for the control. pH, okay? CO2. That's what it's really looking at. Okay? Cerebral perfusion inside the CSF, it looks at what the pH level is. If the pH increases, what do we need to do? We got to get rid of it. Okay? So it tells the brain, hey, I don't like this, breathe off. If the pH drops, conversely, if the pH drops because it becomes acid, okay, we want to breathe more. If the pH increases, we become alkalotic, and we want to lower it back down again. Okay, so if our CO2 increases or our CO2 decreases. Same thing occurs at the carotid bodies and all that stuff, and then at the aortic. Inside the muscles, okay, if we were to go and run a marathon, what do we produce? Lactic acid, okay? Why do we produce lactic acid? Correct, okay. So we're not using enough oxygen to be able to, so we need to convert pyruvic acid over to lactic acid from that standpoint, okay? So that's why we have to re-regulate it. So Inside of our muscles, we have chemoreceptors for lactic acid. If we build up lactic acid, what does it tell the body to do? Get rid of it. I need more oxygen. Okay. At the same time, it's telling the heart to speed up because I got to get rid of the CO2. And all that will come together. So receptors, essentially, what it does is it looks at the PCO2, PHF, and the CSF. Peripherally, changes in the oxygen, plus or minus. Okay, it doesn't really look at the O2 level. Okay, it's really looking at the CO2 level and the pH of the blood. That's the factors in play. Questions on any of that? Head spinning? Good. Good refresher? Yep. Wonderful. All right. Physiology. Okay. So now let's talk just a little bit about the process of inspiration and expiration. Okay. What's inspiration? What's the purpose of inspiration? Pulling air in. Okay. Expiration is to pushing air out. Okay. So inspiration, how does it occur? Diaphragm does what?
Contracts and expands.
Diaphragm contracts, pulls down. What does our intercostal muscles do? Our intercostal muscles contract, opens up, okay? Kids, how good are their intercostal muscles? They suck, okay? Kids don't have good intercostal muscles, so where do the majority of their inspiration occurs? Their belly, their diaphragm, so they become they're belly breathers. That's why they get that seesaw with the really bagging, okay? Or the intercostals because they're trying to blow, the nasal flaring and all that stuff because they're trying to open up the airway passages. That's what the nasal flaring is. All right. So the diaphragm and all that stuff contract, that's an active process. It's all looking at your millimeters of mercury, okay? Negative pressure versus positive pressure and all that stuff. So when we breathe, okay, it's all about changing volume and resistance. Boyle's law, okay, remember that, comes together. Basically looking at pressure and volume, they're inversely proportional to each other. If you increase the pressure, you decrease the volume. If you increase the volume, you decrease the pressure. Yes? Okay? So from that, what we do is if I want to bring in volume, I decrease the pressure down, which allows me to expand open. And inside the chest, that's what we're going to get to. Again, Boyle's negative pressure, looking from the aspect, the diaphragm drops down, the intercostals constrict, they drop, it pulls the pressure down. The outside atmospheric pressure is higher than the intrathoracic pressure, so that pushes or allows air to expand in. Diaphragm relaxes, looking at a balloon, the aspect of the exhalation, the diaphragm relaxes, pressure gets drops, and then that pushes the air out from that standpoint. Right, where do I want to get to? Outside, inspiration, 760 millimeters, okay? That's kind of sort of sea level atmospheric pressure, does change. Inside, when we contract the diaphragm down, it pulls or the intrathoracic pressure decreases, okay? From that is what allows for the air to move in. Conversely, okay, on the other side, when we increase it, and it's not a lot of pressure changes, okay? 763, 765, there's not a lot of pressure changes, but just enough to push things through. Okay. Oxygenation versus ventilation. All right. Differences. Okay. What's oxygenation? These terms.
Oxidation gives the air to the alveoli to have an exchange happen.
Okay, not just air, it is getting, it's specific oxygenation is getting oxygen. Okay, it is utilized in, when you get to the ventilators and when we talk about all that stuff in the future, it's understanding oxygenation versus ventilation, that whole process, and when we go through some of the cases. All right, oxygenation is getting oxygen in and utilizing for metabolism. Okay, where do we use oxygen in metabolism? Ooh, high school biology? What? Inside the cells. What? At the cellular level, good. So we're doing cellular respiration. Okay, respiration is moving air in and out. At the cellular level, is it's taking oxygen and it's converting glucose to energy and all that stuff. Okay, versus ventilation is the actual process of moving air in and out. Looking at the CO2s. That's the major differences from there. All right. Respiration. Oops. Wrong. Okay. Respiration. Okay. The whole process is respiration. But we also have something called, the cellular respiration, which is we're using oxygen at the cellular level. So we ventilate, we bring oxygen in, that's your oxygenation. We circulate it around, get it down to the cells, they dump off, and then from there we throw a little glucose in there, good to go, okay? Fuel the fire. And then the aspect of bringing the CO2 back, pushing the lung, getting the CO2 out. That whole process is the respiration side of it. Measuring, okay, our pulse oximeters and all that stuff. Who do we have problems with pulse oximetry? Cold fingers. Smokers.
Peripheral vascular disease.
Peripheral vascular disease. Old patients? Old people. Okay? Fingernail polish.
Well, like I had somebody with Raynaud's.
Okay, Raynaud's.
Like circulatory issues.
Yep, that all peripheral vascular, all that stuff. Okay. Skin color. What about skin color? Who has problems skin color wise? What? People of darker color actually have the blue wavelength does not diffuse or does not go across. Okay, so black people you can actually have an abnormal O2 level. Okay, just for FYI. Nail, artificial skins, carbon monoxide from that standpoint. Okay. Okay. So why do we need oxygen? Okay. Ultimately, ATP is our money. Okay. That's how our body kind of sort of cashes in everything, is all based upon ATP. Okay, so we need to create and break down glucose to form energy. And we need it as that final electron transport, or inside the electron transport chain. You guys remember that in high school biology? Vaguely? Okay, that final acceptor in the electron transport chain is oxygen. Okay, where do we produce energy? Where inside our body do we produce energy?
What's the powerhouse of the cell?
Mitochondria. Okay. So we take some glucose, C6H12O6, that's the formula for glucose. We give it a bit of oxygen, okay? And then from there inside, we use all the different enzymes and all that stuff, and we break down, we get some water, we get some CO2, and then we get some electricity. Right? It calculates out from that standpoint. So yes, okay, this will be tested again for you guys. Okay. Yeah, no. All right. So glycolysis is outside the mitochondria. We get a little bit of energy from glycolysis. Okay. But the major players that we get is the NAD, okay, and it forms the NADH. From there, that also forms pyruvic acid. Pyruvic acid gets shoved into the mitochondria, goes through the Krebs cycle, okay, and it produces all these other things. From that standpoint, more NADAs, more FADH2s, all of that is then shoved over to the electron transport chain, and it dives down that, and that forms our oxygen, or O2 goes at the bottom of it, and that forms the water. But that's how we get 34 ATP. It's inside that process that we get our energy.
That week and a half of all this crap, and they expect it never forever.
Yeah, little PTSD for anybody?
Yeah.
got some. I see some twitching going on.
Last IST, I joked about how we were going to go to the Krebs site. Didn't do it. Here we are.
Yeah, exactly. I added it.
Yep.
Okay, so again, if we don't have oxygen, we don't have this process. We take pyruvic acid and it gets shoved over to lactic acid because we have to reform the NADs. Okay, we have to regenerate that. That's why we get lactic acid. That's why we get septic patients. We have elevated lactic acid, and we'll talk about more. We can kill the citric acid cycle by different drugs, or we can kill the electron transport chain. Carbon monoxide poisoning, cyanide poisoning kills the electron transport chain. Okay, that's how it does that, decouples things. Aspirin kills the electron transport chain. That's how we kill people with aspirin toxicities. All right, different story. Okay, pulse ox. From the aspect we talked about the pulse ox, the different pieces in the plays, finger, nose, all that stuff. Different pieces from there. Versus the CO2. Again, the CO2 is what the body uses as the chemoreceptors. That's what it uses to figure out what do I need to do. Okay, this is why our our COPD patients have issues with CO2 because they can't regulate it properly depending on. So they become a little bit more oxygen dependent or oxygen regulation side of it. But the CO2 is our metabolism. That's how we know our body is working properly. We have a cardiac arrest. What do we look for? A spike in end-tidal CO2, which we know we have what? We're getting ROSC. That's why. Ventilation. Okay, how do we measure it? It's the partial pressure of CO2 levels. We're breathing it off. That's how we know we're getting things. We look at our capnography and all that stuff. Okay, how do we do it? Nasal end-tidal CO2s from there, or you do your inline on your ET tube and all that stuff. Plays from there, okay? You guys know. From that. EMTs, learn if you don't know how to read end-tidal CO2s, definitely from that standpoint. A little square box. Breathe in. This is not a true square box, maybe a little bit of an asthma patient, get a little bit of shark finning going on, but it's that the back side, we have our inspiration, is we got the deep down, goes across, and we start breathing, and it's that final piece at the tip is our end-tidal CO2. Right. The end of phase 3 before phase 4 is what we're looking at is our end-tidal CO2. That's what we're measuring. Right? And again, our normal end-tidal CO2 is 35 to 45. Good. And we'll go from there. So phase 1 is inspiratory. Phase 2 is you start breathing, and then it goes across. Okay. Questions? Anything in anatomy? Anything in physiology? Anything we need to talk about more again? Yeah.
During COVID, we'd see patients that were breathing normally but having SpO2s like low 80s. They didn't feel air hungry or anything like that, but were low 80s. Is that because the chemoreceptors are not inspiring that? What was the reason behind that?
COVID's killing, or it's stopping the diffusion of oxygen across. That's just the virus itself. Okay. You'll see the same thing like with RSV. Your bronchiolitic patients, the happy wheezers, they have low SpO2s. They're wheezing a little bit, but otherwise they're just sitting there smiling and playing and grabbing mom's phone and all that stuff. That's just the virus. All right. Kind of sort of, do you have to understand the whole process? No from this, but this is how much longer in our volumes, okay? From the aspect of our resting tidal versus our inspiratory, how much can we actually breathe in completely, okay? Versus the expiratory reserve volume is how much can you breathe out, okay? All that together gives our vital capacity versus the functional resilience is the expiratory versus the residual. We have a little bit of volume left even after we breathe everything out, okay? 1,200 mLs from that standpoint. And then ultimately, all of that gives us our total lung capacity. Okay? When you guys start playing with the ventilators soon, okay, this will come to haunt you because understanding our tidal volumes and all that stuff, or what we can do, how we change volumes to actually improve cases for the patient. So what do we do? Okay, our tidal volume is about a half a liter, okay? Calculations, when you look at your predicted body weight or ideal body weight, there's calculations to play from there. You guys are gonna just have a chart. You're gonna look at what their height is in inches, and they're gonna tell you, I want 6 mLs, I want this volume, and you're out the door, okay? So 3 o'clock in the morning, you're not calculating anything. That's the worst thing that you can do. Okay? Residual volume, again, we have 1,200 mLs, okay, of just space at the end it's just always there. The inspiratory reserve, we can actually breathe in an extra 3 liters of air, okay? So we have a lot of ability to bring in air and all that stuff, which allows, again, if I have a CO2 patient, I want to get rid of it, I can expand the lungs a lot to be able to exchange stuff.
I got a question for you.
Yeah.
So in say a patient, I know there is like surgeries where they now, patients with severe COPD, they can remove parts of the lungs that are died off.
Yep.
And supposedly the lung expands. So what if you have a patient that's had half of the lung removed?
Yep.
So is it going to change all that?
No, what will happen from there is the blood in that area that's no longer there, the body will shunt all that blood. They'll actually constrict down the blood vessels, and it shunts the blood to all the other parts that are still functioning, and will oxygenate those.
Okay. So we wouldn't have to adjust like our volume and everything for the...
No, because ultimately in time what you'll do is you'll calculate your minute ventilation, you'll look at what your tidal volume is based upon your ideal body weight. From there, then you calculate out your respiratory, and then you start titrating. Too much CO2, I need to increase stuff. If too low CO2, I need to decrease and go from there. Yep. Yeah, but the amount of lung you have itself won't affect anything. Right. So tidal volume, ideal body weight, predicted body weight, okay? PBW, so there's different terminologies and all that stuff. IDBW, predicted body weight, PBW, it's not our actual. If you look at this picture, okay, obese patient versus skinny patient, okay, what is the lung size? Same, okay? It's the exact same. So that's why we don't use our what is your weight? Okay, someone that's 500 pounds versus 200 pounds, the lung is the exact same. Okay. So yes, if you want to, there's the formulas. Okay, write them down, calculate it out every time you want. Be my guest. Okay, 3 o'clock in the morning, I would say no. Okay, so you take the patient in inches. Okay, that will give you your predicted body weight, and then it's just really 4, 5, 6, 7, 8. Do you want 4 mLs, 6 mLs, 8 mLs? Traditionally, we start off at 6 mLs. Okay. So if you have a patient that's 5 foot, they're 60. If you want from they're 50 pounds, their predicted body weight or their tidal volume is 300 mLs. That's how much they're breathing in. Okay. A 5 foot patient is breathing in 300 mLs. And then you put that through the ventilator and you keep going. One of my pet peeves. How, if at rest, when we're sitting here right now and you guys are trying to fall asleep on me, okay, how fast are we breathing? What's our normal respiratory rate? What? Are we breathing 20 times a minute? No. So what is really our resting respiratory rate? 12, 14. Okay, so like when I'm in the ED and I tell my nurses and then in school for my paramedic students and even the crews over at Pickens, if you're gonna lie to me, okay, don't write down 20. Okay, write down 14. I'll believe you. Okay, or ideally, it's 30 seconds. Count it, calculate it, go from there. Get it accurate. All right, especially if they look like they're breathing fast. Truly, okay? Because once you write down 20, what's the first part of SIRS? What's the respiratory rate of SIRS? 20, okay? So if you write down 20, which is normal, BS, okay, you're actually saying that they're the first part of SIRS, okay? And in sepsis, what's the first thing that changes? Our respiratory rate, okay? Because we got to get rid of the CO2 from the acid. So that's the first thing that changes. So please, don't lie to me. I'll get off my soapbox. Right. So minute ventilation, okay? Minute ventilation is not just how many times we want to, how much volume we move in a minute, okay? Just like cardiac output, what's the formula for cardiac output?
Stroke volume times rate.
Heart rate times stroke volume. Stroke volume is based on preload afterload contractility, okay? So minute ventilation has the same thing. It's something important, okay? You need to be able to, this is unfortunately one number you'll have to calculate at 3 o'clock in the morning. It's an easy calculation, okay? So Minute ventilation, respiratory rate times tidal volume. Tidal volume, where do we get our tidal volume from? The chart, because we're going to measure them out, look at the chart from there, okay? That will give us our, okay, what our tidal volume is. We have to figure out what our respiratory rate is from our minute ventilations, okay? And how do we do that? Okay, we take our volume, we take kind of sort of the ideal, I'll get there in a second, okay? So just minute ventilation, our tidal volume times our respiratory rate, and this kind of sort of will give us what our minute ventilation is. We're going to work backwards, though, to get our respiratory rate, okay, and what our minute ventilations are. So for this patient that's breathing 14 times a minute, okay, all of us right now, okay, falling asleep, okay, we're breathing 12 to 14, okay. If you're a female, again, from that aspect, okay, 400, 500 ml, breathe, because occasionally you'll take a sigh, get that. You're going to breathe 8.5 liters per minute. Most of us at rest, we're breathing about 6 to 7 liters, which is cardiac output. We circulate 5 liters, so they kind of sort of coincide with each other. So how do we actually calculate our minute ventilation? Or how do we get to our minute ventilation? Okay. These will be the numbers, and you'll have in your guidelines and all that stuff to remember. For adult patients, okay, our normal minute ventilation is 100 mLs per kilogram. So our 5-foot patient, that was 50 kilograms, okay, what's her minute ventilation? 5 liters, 5,000 mLs. If her tidal volume at 6 mLs was 300 mLs, okay, so 5,000 divided by 300, or 50 divided by 3 is 15-ish, okay? So her respiratory rate is 15 to 16, okay? It really is that simple, okay? So you have to calculate out what your ideal minute ventilation is, and then divide your ml to get your respiratory rate. For kids, 150 to 200 because they need more oxygen to be able to, for the metabolism side.
Yes, we're getting those right there.
Yeah. Yep, this is what you guys are getting. They are. It is very simple.
Oh, actually, we're donating one ticket.
That's how we got him down here for a few seconds.
Yeah, we
What are we doing with the other
Yeah.
one? Is that next year when he comes back next year?
No, I'm gonna use the other one for training.
Okay.
So.
Yeah, it's good. It's actually has a lot of purposes. So, all right. So how do we look at, okay? Again, our target, 35 to 45. If they have low CO2s versus high, is kind of sort of how we're going to change or how much ventilation that we need to be able to offset stuff, okay? It's, you know, from there, they're going to potentially need 18 to 20, okay, liters per minute of ventilation to get rid of that entitled CO2 of 20. Okay? And so you'll have to potentially make a lot of adjustments on the ventilators. And again, it's a play. You just don't put them on there and just leave them there. You actually have to look at it and see how things are going for them.
How quickly, I don't know if you can get it, but how quickly would we make those adjustments?
3 to 5 minutes on average. Okay? If,
They're staying at 20 to 3 minutes?
yeah,
Minutes?
yep. Then make an adjustment.
Okay.
Then make an adjustment. Yep. You got to give it a little bit of time for the body to process. Right? Again, another topic, another day, another lecture. All right. Assessment-wise, okay? Kind of sort of figuring out, okay, one side, okay? If they're talking to you, okay, what do they have? They're oxygenating, they have a patent airway, they also have a pulse, okay? That's the number one way to assess somebody. If they can say hi to you and talk to you, they have everything. True. We're not dealing with zombies. Okay. All right. From there, all right, when you're looking at the respiratory rate, all right, look at the rhythm, the rate, the quality, too fast, too slow. Are they chain stoking? Do they have that period of apnea? They stop, okay, with the chain stoke breathing, which brains them. Are they Kussmaul's breathing, okay, for your DKA patients and all that stuff. Skin color, okay, people of color, all right, where do you want to look at for cyanosis? Fingernail beds, gums, okay. So knowing different places from there. Okay, Can they speak in full sentences? If they're talking one-word sentence, right, they're having a problem versus they're carrying a conversation. They say, I can't breathe, but yet they're speaking. They just won't shut up. Okay? We've all had those patients. You're doing fine. Okay? Keep breathing. And then really you're asking yourself, is it adequate or inadequate? Okay? For the kids, what's the one thing that we want to think about with the kids? Okay, what are we taught at the beginning? How do we assess a kid? What's the first thing that we want to look at? Facial structure and all that stuff. But if you open the door and you look at the kid, what is that called? Sick versus non-sick. That is called the... Very good. Yes! Yeah. So don't forget your pediatric assessment triangle. What do they look like? What is their parents? Are they mom holding? Are they floppy kid from that standpoint? Are they breathing fast? Intercostal, nasal retractions, and all that stuff. And then looking at their nail beds. Okay. Emergency problems. Okay. Do we have issues with inspiration or expiration? Can we get it in and out? Or can we ventilate? Okay. Do we actually have a problem with the diffusion of gas? That's oxygenation. Okay. Oxygenation is getting the gas across or getting the CO2 back. From there, is there an issue with the perfusion? Remember that lung that I had at the bottom, okay? Are we not getting enough blood around? Do they have a PE? They can't circulate from there, okay? Or did you take a baseball bat to the head, okay, and you're no longer breathing because you got a epidural hematoma and it's pushing down on the brainstem and you're having herniation, right? Those are the factors. All right. Scenario one, okay? So we're going to talk a little about respiratory failures. 56-year-old, 20-pound weight gain. Is that good or bad? Okay. History of diabetes, hypertension, renal insufficiency, CHF. Okay. Heart rate's 135, blood pressure is 213 over 113. Okay. His end-tidal CO2 is 29. He's breathing 71% is his oxygen level. Okay. Good or bad? What does he have? What are you going to do? CHF exacerbation. Okay. What? What do you? Yep. Okay. All right, you got wet lungs now, you got the pink frothy sputum coming out. Okay? Exactly. What? Yeah, exactly. Okay? So you start him on CPAP. Okay? Now his pressure drops to 86 over 60.
What'd you set the CPAP at?
What do you set the CPAP? What are you guys' your initial pressures for CPAP titration and all that stuff? What do you start at? Yeah. Okay.
No, what's the peak?
What's your PEEP on your CPAP? 5. Okay. 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 Up to 10, yeah, on the, if you, okay. So on your vents, you can actually drive your PEEP up in your vents in the future up to 20. So you actually will have the ability to really drive your PEEP up. Okay. So for this patient, his blood pressure drops to 86 over 60. What are you going to do for him? Take the CPAP off. If you put him on nitro, you can take the nitro off, which that's another topic, another day. Okay. What else are you going to do for him? Push those epis, something from that standpoint. Okay. So what's wrong with this patient? Okay. What type of respiratory failure is he in? Okay. I'm going to tell you there's 4 types.
Y'all know there's types of respiratory failure?
Okay. Bad, really bad risk. Yeah, exactly. All right.
Crashing, crashed.
Yeah, exactly. So he's actually in type 1 respiratory failure. Okay. So he's the initial piece of it is called SCAPE, which is again it's another topic, another day, and all that stuff. We're going to talk about CHF patients. All right. But he's in his oxygen levels low. Okay. He's not oxygenating, so he's in type 1 respiratory failure. Right. The way that I remember that there's type 1O equals oxygen. Right? And that will come to, for you guys again, when you do the ventilators and all that stuff, because how do we treat the oxygen issues? There's 2 ways that we can actually increase oxygen. The first way is by not so much increase in respirations, we want to give more oxygen, or we need to increase not so much tidal volume, because tidal volume, we'll get there again, okay? I like you guys the way that you're thinking. Increase PEEP, okay? So if I increase PEEP, So that's why we start off at 5 and their oxygen level is still low. We increase the PEEP because now I want to drive, the purpose of PEEP is to drive oxygen across at the alveolar. I have fluid at the alveolar. I need to get more pressure at the alveoli to push that oxygen across. That's what PEEP does for us. So when we start to blow up, what's the hardest part of blowing up a balloon? That very first beginning. Okay, that first breath. That's what hard, okay? If we let the balloon constrict every time, that's the issue. So PEEP is positive and expiratory pressure. We blow the balloon up and hold it there, so the next time I take a breath, it allows me to expand. But it's also that pressure that's pushing against anything inside the lungs to drive oxygenation. Right to left shunt, okay, is the issues in the long-term CO2 patients. Okay. So how do we improve type 1 oxygen level respiratory failure? We need to either give them, again, more oxygen, okay, or more PEEP, okay? EMT, advanced EMT, paramedic, what level is this? All, but at the who does this? No. EMTs. Love you, paramedics, guys. Okay? This isn't you. Paramedics, this isn't you. Okay? This is my EMTs. Okay? CPAP. Okay? There's nothing in here for a paramedic to do. Okay? This is a BLS call. Have a good day. Wouldn't quite go there, but okay? But that is the aspect of taking care of it. Okay? All right, so non-invasive ventilation, huge. It has a lot of factors. I love it. Okay? I wrote a chapter on it in an article from that standpoint. I get pissed off because you guys actually in the pre-hospital setting changed how patients come. Okay? I no longer get to intubate patients because of CPAP use. You guys actually change outcomes. Okay. 72-year-old, case 2, okay? Not acting herself, okay? 3 liters, and she's at 150 feet of tubing. It wraps around the whole house, out the door, okay? It gets kinked in multiple places. Right? She's been smoking for 60 years, since the age of 12, okay? Respiratory rate 27, her oxygen is 90, and her end tidal, when you throw it on, is 95. Okay? Is that an issue?
Yeah, no, we had a patient on the RSI that the initial ETCO2 before RSI was like 75, and once they put them on RSI, it jumped up to like 250 because they were able to get that out.
Yeah, able to actually ventilate it off.
And it came down when the ventilations post RSI, when we're able to breathe for them, it started coming down because we're able to actually off-gas it. I don't know if they lived or not. They weren't in great shape to begin with, so they lived through the RSI. They lived till we got into the hospital.
Right.
That's our job done.
Check. But did they die? But did you? Okay. So type 2 respiratory failure. Okay. CO2, type 2. Type 1, oxygen. Okay. Increased CO2 is type 2. Okay. And it's a caveat. Yeah, in type 2, you also have a low oxygen level. Okay. So you have a low oxygen with an elevated CO2 level. That's type 2. So how do we get rid of CO2? What do we need to do? Okay. Solution to pollution is dilution. How do we dilute CO2? What do we do? If we give them oxygen, is oxygen going to take care of that problem? We need to ventilate them. So how do we ventilate them? What do? We increase respiratory rate, okay? Or we increase, not so much PEEP, because what does PEEP do for us? It forces that oxygen to allow for diffusion. So that's not going to really help us. Tidal volume. So we want to open up. So if I take a container, okay, if I put a whole bunch of sugar in a can of Coke versus a whole bunch of sugar in a 2-liter Coke, okay, what's the differences between the concentration of that sugar? Inside the can, it's going to be more concentrated versus that 2-liter bottle. So that's the same premise. Okay? So type 2 respiratory is a hypoxic drive. Again, it looks at inside the cells and all that stuff, our baroreceptors, our aortic arch, and even down into the muscles from there. That's that CO2 that we do. And it's a perfusion mismatch problem going on. So how do we take care of it? We need to increase our minute ventilation. What's our minute ventilation? What's the formula for minute ventilation? Respiratory rate times tidal volume. Okay? So you change your minute ventilation. Okay? Type 2 CO2 change minute ventilation. How do we do that? I don't care. You need to do one of two things.
Can you do both and just reevaluate?
Yes. Okay. Traditionally, I mean, you can go, I would do one, and then if that's not working, then change. Because if you change both, you might have problems. You jack up your vent alarms and all that stuff.
Your vent's gonna feel all pissy when you get to the
Exactly. Okay. But if you know, you can. Okay. Or calculate out, did I actually start off with the right minute ventilation? Did I use 100 mLs where I should have been using 120 ml per kilogram for my septic old patient that has that end tidal elevated? Okay. And then go from there. But yes, you can increase both. So increase with the respiratory rate. Okay. And remember, Christ is watching you. Okay. Or from the aspect of increasing your actual volume and all that stuff. 47-year-old, surgery, okay, just had surgery, went home, okay. Non-productive cough, we got some crackles at the bases, oxygen level is 88, her end-tidal is 31, okay. What type of respiratory failure does she have?
Type 3.
Yes, she has type 3. Okay, so yes, she has type 3. Type 3 is kind of sort of unfortunately like type 1, okay? The problem or the difference is we caused it, okay? I caused it, or the anesthesiologist, the surgeon. There's something surgical or something idiopathic that the doctors did. That's kind of sort of what type 3 is, okay? But treatment-wise is the exact same as type 1. And how do we take care of type 1? What do? Oxygen. Or PEEP, okay? So type 1 is oxygen or PEEP. Type 2, CO2 is ventilation, which is respiratory rate or tidal volume. Change your minute ventilation, okay? Anesthesia, incision, airway problems, okay? We have decreased in our residual capacity. Obese patients, a lot of people that have ascites, they can get a type 3 respiratory failure too. Conscious, restless, 82-year-old, okay, from the nursing home. Okay, from that standpoint, history of emphysema, she's tachy, irregular, her blood pressure is 72, SpO2 is 80, her end tidal is 24. Okay, sepsis, good. Okay, she's cyanotic, she got rhonchi rales, she's been having some cold flu symptoms for the past week. She's got pneumonia going on, okay. That's her EKG. Anything special?
Mine is old.
What? Okay. Is she really sinus? Okay, so she's actually AFib-ish. So, do we need to take care of this? Do we need to do anything with this? Because remember, sepsis can actually drive AFib, okay? So don't worry about that, all right? Nothing to do. Just, that's bonus points for you guys, education-wise.
Like when you're called to defense, we don't worry about that.
Right.
Noted.
Right. So this is type 4, yes, okay? Yeah.
Wow, Rob, you're smart.
So sepsis is type 4 respiratory failure. Okay, the two go again from the aspect of treatment and all that stuff, but that is, okay? So they have a hyperperfusion state. They're not getting the oxygen across. They're not getting rid of the CO2s. How do we take care of that? Of course, take care of the sepsis side of it. That's how you're going to cure the respiratory failure. Yes, you may need to meet them oxygen, and yes, you may need to put them on ventilations. Yes, you may need to intubate them from that. But you have to take care of the sepsis process. Looking at end titles. okay, her end tidal was 26, okay? So there's literature that shows our correlation of our end tidal CO2 with our lactic acid, okay? So once you start driving with an end tidal less than 25, the patient actually has lactic acid greater than 4, okay? And on here, this is a little scatter plot, okay? Just to kind of sort of barf you guys out from there. When our end tidal is low, okay, how much is our lactic acid? So here at a 10, our lactic acid is actually 12 to 14. Okay? Versus down at the other end, where our end tidal is 45, our serum lactic acid is down around 2 or less.
I think the one we're looking at here.
Okay. So it does correlate. This is trauma patient, but this goes hand in hand of looking at our septic patients. Okay, so you can actually diagnose a true severe sepsis based upon the usage of that. Of course, they got a low blood pressure and all that stuff. Yeah, I mean, it's kind of obvious at times. All right. And ventilations, okay? If we hold our ventilations constant, specifically, okay, our end tidal CO2 is directly related to our cardiac output, okay? So again, if we have low end tidal CO2, which means our cardiac output is 2. So if we have someone in cardiac arrest and their end tidal is 10, how good is their cardiac output? It's not, okay? This is why we know that when we get a spike in our end tidal CO2, what's gonna happen to our heart? What's going on? It start working. We're starting to increase our cardiac output. That's the metabolism side of it. That's why it's important to know and understand. All right. Again, just a reminder, type 1 is oxygen. How do we take care of oxygen problems? More oxygen or PEEP. Type 2 is a ventilation problem, but it's a CO2 problem. Yes, they can have an underlying oxygen problem with it, but it's predominantly CO2. What do we take care of that? Changing the exactly, good. Change your minute of ventilation. Okay. Type 3, doctor's fault. We did it. Idio, okay. We caused it. And then type 4 is our sepsis. All right, so 5, okay? Dollar General, person, blue, unresponsive, okay? Foaming, okay? Need on the right AC, okay?
Already got access.
Opioid.
Okay,
Overdose.
okay, got overdose, okay? SpO2 82 could be lower, pinpoint pupils, they're overdose, okay? What's the problem here?
They're not able to respirate.
The respiratory drive, okay? So what type of respiratory failure is this though? Nope. There's only 4. What? Okay, so this is getting into a 1. Now let's say if I said that their end tidal, okay, they don't have a really end tidal right now, okay? Why don't they have an end tidal? They're not breathing, they're not ventilating it off, okay? But let's say you start BVMing them and their end tidal is 60 or 70. Okay, what type of failure is this? 2 in 1, okay? So you can actually have a mixed path, okay, from that standpoint. So you can have a low, and again, it depends on what the cause of it is. If you like this video, please subscribe to the YouTube channel Prehospital Physician.